So hello everybody, in this video we'll be discussing about the pathology and the radiological findings that are found in a typical case of tuberculosis. Tuberculosis is perhaps the most important infectious disease in an Indian context, and as such we must know everything about it. And one question of tuberculosis is expected in both the theory and viva exams of pathology, microbiology and pharmacology of your second professional exams. So it's a vast topic and you literally have to know everything about it. So I'll be dealing with tuberculosis in 3 videos. In the first, like I said, I'll be talking about the pathology and the radiological findings. The radiological findings are just to boost your understanding of the disease. They aren't expected to be asked in your exams, but again it's very useful to know them. And in the second video I'll be discussing about the microbiological diagnosis and the latest RNTCP guidelines. And in the final video I'll be talking about the anti-tubercular drugs and the various treatment regimens. Okay, so let's begin. So over here we have a typical history where a 47-year-old man has presented to the outpatient department complaining of cough, evening rise of temperature and night sweats. So cough, evening rise of temperature and night sweats for the past 2 months. This is a typical history which you will be given in your microbiology papers. The thing you have to notice the most over here is this timeline of 2 months. So TB is a chronic disease, and as such history of cough and temperature, night sweats for let's say 1 week, you can't say it's TB, but 1 or 2 months, yes, that definitely points towards TB. However, this evening rise of temperature and night sweats, these two symptoms can be correlated to another disease which you have probably learned in hematology. Don't they sound similar to the B symptoms you find in Hodgkin's lymphoma? Yeah. So of course there are subtle differences, the presence of the cough, another, there will be no chest x-ray findings as such. Of course the lymphadenopathy findings will also be there, and the various pattern of lymphadenopathy, the extra-axial spread, and then the CD marker evaluation, peripheral blood smear evaluation, all of them will point towards Hodgkin's lymphoma finding. Okay. However, this cough, evening rise of temperature, night sweats, and this timeline of 2 months will point towards will be more in favor of tuberculosis. So now let's move on and study a bit about the disease itself. The management of such a case will include both the diagnosis and the treatment portions, which I'll cover in videos 2 and 3. Now let's just learn the basic pathology and the radiological findings. So of course our provisional diagnosis is pulmonary tuberculosis from the case history, and the etiological agents for this disease are all the members of the Mycobacterium tuberculosis complex. So you have to remember the names of all of these members. There are 1, 2, 3, 4, 5, 6, 7, 8, 9. The names of all these 9 members have to be remembered by heart, and they will be asked in your practical exams. When you will be doing that acid fast bacilli smear, your examiner will ask you about the names of all the Mycobacterium tuberculosis complex members. So of course the first member is Mycobacterium tuberculosis sensu stricto. Then there is 2 more members which cause disease exclusively in humans, that is Mycobacterium cannati and Mycobacterium africanum. Okay, so tuberculosis, cannati and africanum, these 3 cause exclusive human infection. Now bovis and capri, they cause infection from cows. Okay, so the rest of the diseases barring Mycobacterium tuberculosis, cannati and africanum are all zoonosis. From bovis and capri we get it from cows, pinnipedi we get it from seals and sea lions, mungai from banded mongooses, oryges from oryxes, and microti from rodents. Okay, so it's a bit tough to remember this list, but again you have to remember this list. And no, I couldn't find any acronyms or any mnemonics to help you remember, but yeah, you have to remember this. Now let's move on to a bit about the epidemiological data. Do you know the incidence of tuberculosis, that is the number of new cases of tuberculosis which are occurring every year in India, is approximately 204 per lakh population, and of this 10 per lakh is approximately 10 per lakh is of the multi-drug resistant type. So you can understand that Mycobacterium tuberculosis is causing a huge public health problem, and the mortality from this is around 10 per lakh population. So the most important thing with regards to tuberculosis is that tuberculosis can affect any organ of the body, and if you when you come into eye, ENT, and then move on to medicine, surgery, pediatrics, gynecology and obstetrics, you'll understand that tuberculosis will be dealt with in all of these subjects because they affect each and every one of these organs. Okay, so now let's move on. So what is the typical course that occurs in a TB infection? Now what happens is that when there is an exposure to TB bacilli, now it is estimated that approximately 40% of the Indian population will be exposed to TB bacilli. It will result in something called as a primary tuberculosis infection. In persons with good immunity and / or who have been vaccinated, there will be a resolution of this infection. In less than 1 to 2% of cases, and this especially concerns children in the pediatric age group, they will lead to a condition known as primary progressive tuberculosis. And in a very small fraction as well, that is approximately 2 to 4% of cases. Mind you, this 2 to 4% is a part of this 40%. Okay, it's not the whole Indian population I'm talking about, it's the 40% who have been exposed. Of them, 2 to 4% will land up in this latent TB form. This 95% and this 1 to 2% is also a part of this 40%. Okay, so this latent TB infection can have two outcomes. One is that there will be a resolution, or it might lead to something known as a secondary tuberculosis or a post-primary tuberculosis. And this secondary tuberculosis is actually the focus of the RNTCP program. So this secondary tuberculosis will be 1 to 2% of this latent tuberculosis. So 1 to 2% of those who have latent tuberculosis will land up with primary progressive tuberculosis. Though the percentages look very small, but you have to understand that the Indian population is 130 crores. So if you apply that demography to these percentages, you'll understand why it's such a huge public health problem. Anyway, let's move on. So what exactly does happen? Why is the tuberculous bacilli so resistant and has such chronic course of illness? So I have summarized a lot of findings after scourging a variety of resources. Please pay attention for the next 2 minutes, and I'm sure you will be understanding TB very well. So what happens is that once the bacilli enter the body, less than 10% will actually reach the alveoli. Most of them will be trapped in the airways and subsequently eliminated. Once inside the alveoli, what will happen is that the alveolar macrophages, which have not been activated, the bacilli will stick to these macrophages via a variety of receptors. One is this type A scavenger receptor, one is this mannose receptor, one are the complement receptors, variety of complement receptors, and the another is this IgG Fc gamma receptor. So these are 4 classes of receptors to which this bacilli can bind. Following adhesion, there will be phagocytosis. Now you have to remember that C3b and C3bi, that is, these complement products, will promote phagocytosis. On the other hand, surfactant protein B will in fact prevent phagocytosis. So once it is phagocytosed, what will happen is that the bacilli will prevent phagosome lysosome fusion, and once this has been achieved, it will replicate and then burst out of this macrophage and infect subsequent macrophages. Now how does it inhibit the phagosome lysosome fusion? Via the lipoarabinomannan, which is a component of the bacterial cell wall, it will inhibit the calcium calmonulin pathway. It will also inhibit production of phosphatidylinositol triphosphate, and as a result of these two things, there will be inhibition of phagosome lysosome fusion. The bacilli will also inhibit autophagy. So a combination of these three factors will ultimately lead to promotion of survival of the bacilli inside the macrophage. Now, where is this lipoarabinomannan coming from? Like I said, it's from the cell wall. This is the typical structure of the cell wall. First, we have these acyl lipids. Then we have this mycolic acid. This mycolic acid is the characteristic of the Mycobacterium genus. Then we have this arabinogalactan. Then we have peptidoglycan, and then we have the cell membrane. Okay. There are these transversely running protein structures which are the lipoarabinomannan, and these pink colored are the surface proteins. So this is the typical structure of the mycobacterial cell wall. And this lipoarabinomannan is, like I said, the factor which mostly promotes the phagosome lysosome fusion inhibition. And actually, in recent years, a new technique has come up to diagnose tuberculosis, and that is the detection of lipoarabinomannan levels in the urine of a tuberculosis patient. However, till date, this has been restricted to AIDS patients whose CD4 counts are less than 40 per microliter. In such patients, it's found that the lipoarabinomannan assay of the urine is a very sensitive test to detect tuberculosis. I'll talk more about it in the second video. And since we're talking about cell wall, I'll just mention briefly that what are the three essential criteria that a bacteria needs to fulfill to be included in the Mycobacterial genus. One is that they should have mycolic acid in the cell wall. Next is they should be acid fast. What is acid fastness and how do we use it in the microbiology? I'll discuss it in the second video. And they also must have high G+C content in the genome. The G+C content should be approximately 60 to 70%. Only if a bacteria satisfies all these three criteria, then only will it be included in the Mycobacterium genus. Okay. So the bacteria has successfully inhibited phagosome lysosome fusion. Now what happens? Now there is expression of a EX1 secretion system, which is found in the repeat domain 1 of the genome of the bacterium. I know these terms are a bit complicated, but just bear with me. They express two factors. One is the ESAT6. ESAT means early secretory antigen. Another is the CFP10. Okay, these two factors will promote the multiplication of bacteria inside the macrophage. Ultimately, when they have reached a sufficient level, they will burst out, and the process will continue. Now, this ESAT6 and CFP10 have two clinical importance. One is that detection of ESAT6 and CFP10 via interferon gamma release assays are newer techniques being used to diagnose tuberculosis infection, active tuberculosis infection, that is. However, one must remember that this ESAT6 and CFP10 are actually absent in the BCG vaccine, and that is the reason for the reduced virulence, and that is why we use it in the immunization program. Okay, so the usefulness of this ESAT6 and CFP10 in microbiological diagnosis, I'll again discuss it in the second video. Okay, so now let's move on to some of the gross pathological findings that we find in tuberculosis. In a case of primary progressive tuberculosis, or sometimes in case of a primary tuberculosis as well, what we find is that there is a Gons focus. Gons focus is basically lung parenchymal evidence of primary tuberculosis, and it is actually a subpleural fibrocaseous necrotic area. Okay. When you add the presence of hilar lymphadenopathy, the summation is called something known as a Gons complex, and once calcification has set in, we call it the Ranke's complex. Okay, so these are the three pathological findings. I'll show you the images after this. These are the three terminologies, and these are commonly found in a case of primary progressive tuberculosis. Okay, primary tuberculosis, rarely you will find the Gons focus maybe on an X-ray, but it will be more of an incidental finding. A patient won't come to you when he has just developed a Gons focus. Okay. However, if the disease is a primary progressive form, then the child will usually come to you, and you may find on a chest X-ray or a HRCT chest, you will find a Gons focus. Okay. Now, let's move on to the main thing, which is the focus of the RNHCP program, and that is the post-primary or the secondary tuberculosis. So what happens is that um, it is basically a reinfection or reactivation of the existing bacilli. So either a person who has been exposed, there will be a reinfection, or it will be a reactivation of the bacilli which had laid dormant in the body. Okay, it is the most common type of tuberculosis which we find in India. So first there will be parenchymal infiltrates, then there will be caseous necrosis followed by its liquefaction, then there will be cavitation. If there is a thick walled cavity with adjacent consolidation, this is absolute proof that it is an active form of tuberculosis. Following cavitation, there will be fibrosis and lung distraction. And because of this, the trachea may be shifted and there will be mediastinal shift. And finally, there will be bronchogenic spread, and a bronchopneumonia-like pattern may be observed in the chest. Okay. And one must remember that the most common site for this post-primary or secondary tuberculosis is the upper lobe, posterior segment of the upper lobe or the superior segment of the lower lobe. And why is that? I hope you remember from your first year physiology that the ventilation perfusion ratio is maximum at the lung apex. Now, though the perfusion is low, ventilation perfusion ratio is high, the perfusion is low, and even the ventilation is low, but not so low as the perfusion, and so a large amount of oxygen will be available for the bacteria to survive, okay, and multiply. So that is why the ventilation perfusion ratio is a very important factor determining where the secondary tuberculosis will occur. So now let us move on to a few of the eponyms which are associated with tuberculosis. First is this pulse lesion. Pulse lesion is commonly found at the lung apex and there is no lymphadenopathy. And this Asman focus is found in the infraclavicular portion, and both pulse lesion and Asman's focus are commonly observed with post-primary form of tuberculosis. Now you can see that over here, this is the pulse lesion at the lung apex, and this is commonly an Asman focus. This is a schematic diagram representing the Asman's focus. Now, miliary tuberculosis, there will be hematogenous dissemination, and this will appear as 1 to 3 millimeter diameter nodules, okay, throughout the lung or even other organs as well. And this is also most commonly associated with a post-primary form of tuberculosis. Then a few eponyms which are associated with secondary tuberculosis. First is the Rich's focus, which is a TB granuloma in the brain cortex. Okay, so this is your Rich's focus over here. Next, this Weger's focus is basically a subintimal foci in the pulmonary veins. Simmons focus is a localized foci in the liver, and a Simon focus is found at the lung apex, where the primary tuberculosis is elsewhere in the body and spreads to the lung hematogenously. Okay, so over here the lung apex is again involved, but the primary tuberculosis infection is somewhere else in the body, perhaps the gastrointestinal system, the skin, anywhere, and from there it hematogenously spreads to the lung apex. So these are a few of the important eponyms which are associated with tuberculosis. So now I'll move on to the radiological progression of disease. Now before we move on to the radiological progression, you should have a basic understanding of how a chest x-ray looks, especially in a PR view, okay, because this is the most commonly used x-ray view, especially for for the chest radiographs. There are other views as well, the AP view, the oblique views, the lateral views, but by far the most important is the chest x-ray PA view, and you should have a basic understanding about this, and that will facilitate you not only in this case but in the future as well. So let's move on, start from the easy portions. Okay, so this is the clavicle. I'm sure all of you can appreciate it, and over here you can see certain conical projections, and this will actually be a central landmark, and that is the vertebral processes. Okay, and the medial ends of the clavicle will be a lateral landmark. And what are these landmarks for? This is the landmarks for ensuring that a proper orientation of the X-ray has been obtained. Okay, so if you draw a straight line through these central landmarks and a straight line through these lateral landmarks, okay, if the distance on other side on both sides are equal, then you'll understand that this radiograph has been obtained in a proper orientation and it's good to go. Okay, so now over here the ribs you can see going like this. This is actually the posterior ends of the ribs. Okay, and the ribs which go like this, okay, here, these are the anterior ends. So don't get confused that these are the anterior ends. Okay, these are the posterior ends. The chest X-ray beam is going from the posterior to the anterior side, and that's why this is appearing more prominent. So these are the posterior end of ribs, these are anterior ends of the ribs, and these are the two hemidiaphragms, the right hemidiaphragm and the left hemidiaphragm. Okay, now let's move on to the heart shadow. Okay, so you know that there are two borders, the right heart border and the left heart border. Okay, so this portion represents the superior vena cava, this will represent the right ventricle, and this small portion over here will represent the inferior vena cava. This portion over here on the left heart border is the aortic knuckle. This portion over here is the pulmonary artery. This small projection over here will be your left auricle, and this is the left ventricle. Okay, now remember this is the left auricle and not the left atrium. This is the ear-shaped appendage of the left atrium. And now I'll give a very important concept with regards to the understanding whether in a case of cardiomegaly can be diagnosed from such a radiograph. So what you need to understand is that we need to draw again a straight line, preferably to the central landmark, and from either side we have to gauge the maximum transverse diameter of the heart shadow. Okay, suppose on this side is A and its side is B, we have to add it up, and then we have to gauge the maximum transverse diameter of the thorax. Suppose that's capital B. Okay, so the cardiothoracic ratio is A plus B divided by capital B. Normally this ratio for a PA view is less than 0.5. However, if this is more than 0.55 on a chest X-ray PA view, then it's a confirmed case of cardiomegaly. However, if the chest X-ray was taken in AP view, then the cardiothoracic ratio has to be more than 0.6 for it to be diagnosed as a case of cardiomegaly, because in AP view the heart looks a bit enlarged. Why? It's a bit complicated explanation for that. I'll deal with it in another video. Okay, so chest X-ray PA view, if the cardiothoracic ratio is more than 0.55, then it's a confirmed case of cardiomegaly. Now let's have a understanding of the hilar shadows. This is the right hilar point, this is the left hilar point. Okay, this thing projecting downwards, this is actually the lower lobe pulmonary artery, and this thing projecting up above is the superior pulmonary vein. Okay, and over here there will be lymph nodes as well, and over here I'm sure you know what this is. This is the gas fundic gas shadow. Okay, this is not gas under the diaphragm. Okay, this is, I intentionally mentioned it over here because students often say that this is the gas under the diaphragm. No, yes, it is a gas shadow present under the diaphragm, but this is not gas under the diaphragm. Gas under the diaphragm is seen in conditions where there is a perforation of the stomach wall. The gas has come out. No, this is a simple shadow of the fundic gas. Okay. So finally, a bit about the lobar architecture. As you know, the right lung will have 3 lobes and the left lung will have 2 lobes. These are the 2 fissures. This is the right upper lobe, right middle lobe, and the right lower lobe. This is the left upper lobe and the left lower lobe. The cardiac shadow on the left side will correspond to the lingular segment. This is the trachea. Okay, and these are the 2 claustrophrenic angles. Claustrophrenic angles, you know, accumulation of fluid, pleural effusion, meniscus sign. These are all important. So these are a few important landmarks, the normal radiological findings in case of a chest X-ray, just to promote a basic understanding, so that when something is out of place, at least you recognize what it is that is out of place. You need to know the sign, you need to know the diagnosis, but just to know that something is out of place over there. Okay. So over here, let's begin with the radiological progression of the disease. This nodule over here, this is the Gons focus. Okay. And when there is involvement of the hilar lymph nodes, like I said, the combination of the two will be called as your Gons complex. And finally, when there has been calcification, as you can see over here, these dense white shadows, these form the Ranke's complex. Okay. Now for secondary tuberculosis, you can see over here that there has been a cavitation over here. Okay, this cavitation you will observe in your secondary tuberculosis progression. And one thing I'd like to mention over here, if you read about it in mycology, you'll probably correlate it with better. Commonly, aspergilloma occurs, that is a fungus infection occurs in a previously formed tuberculous cavity. Okay, and this radiological sign is called a Monod sign. Okay, you will see a crescent of air like this. Mind you, this is not the air crescent sign. The air crescent sign is something different, but a crescent of air over here can be seen. This is the Monod sign. Okay, the air crescent sign, I'll discuss it in a later video. Okay, it's not the same as Monod sign. So this is an evidence of aspergilloma in a tuberculous cavity. Okay, and this is radiological evidence of miliary tuberculosis. You can see the numerous nodules over here spread throughout the lung. There may be evidence of it in other organs as well. Okay, so this is a typical radiological finding of miliary tuberculosis. And finally, this is a HRCT, that is a high resolution computerized tomography showing a tree in bud appearance. Tree in bud appearance is observed when there is bronchopneumonia like spread of the tuberculous bacilli throughout the lung. And you can see how it's like the tree branches are branching and budding. So this is a typical appearance known as the tree in bud appearance seen in HRCT chest in case of bronchopneumonia like spread of tuberculosis. Okay, so with this we come to the end of this video. It's been rather a long video, one of my longer videos, and I've been blabbing on for a long time, but I hope you got some important concepts which will greatly benefit you, I hope, in your exams. In the next video I'll come back with the microbiological diagnosis. Thank you.